Thank you.
Thank you. So I'm going to skip with the introductions because Tori did such an incredible job. The only thing I'd like to add is that Dr. Levy, since she's come on board at Turo, has changed the entire atmosphere of the school, where students are now excited about the possibility of understanding more about the challenges that they face when patients come in with pain. So this is another housekeeping disclosure. We both work at Turo. The CE program is delivered without commercial support, and the CE is being jointly provided by CE Zoom. We put together a list of goals for this evening. The goals are reasonable, ones that you would come up with on your own, but it is for the most part to help you have a better understanding of what facial pain is all about, what you need to do when you make the decision that there is a patient with a non-odontogenic source and that the pain is from the 10% that was referred to in the video at the beginning, and how you deal with other practitioners to help you move forward. So let's have a deeper understanding. When you think about dentistry, what is dentistry? You could think about the response that you had to your interview when you went to dental school and they said, why did you choose dentistry? And everybody came up with the same one. I love the sciences. I like to use my hands. I'm going to marry the two together. But is that really what dentistry is? So when I went to look it up in the Encyclopedia Britannica, which was, as I was growing up, my written Google, it basically focuses on the fact that we are a treatment-oriented profession. And then if you move on to the American Dental Association, they basically do the same thing with their explanation. They start with performance. And at the end, they talk about identification and diagnosis and then treatment. I would really prefer to turn that around and say, we identify, we diagnose, and we don't actually treatment plan, but we plan treatment. So it's a slightly different approach. And now if we try to see why do people actually go to the dentist, we will find that for the most part, 70% of the patients who show up in an office come in because they're in pain. Most people, 40%, suffer some sort of pain. And as opposed to the only 3.5% of Chinese adults who visited for routine dental care, 81% come because they're in pain. So we are already seeing the people who have moved through the funnel, the people who are self-reporting pain, and they are saying to themselves that I have to go to somebody who's an expert in pain. And dentists should be very proud of the fact that 90% of the time, they can incredibly handle acute pain. And when patients come in pain, they normally leave without it. We're going to focus on the 10%, but we have to also focus on the fact that Friday is Toothache Day. So this is coming at a very, very opportune time so that we can celebrate Toothache Day by helping people take care of their toothaches. So let's jump into a case. My teeth hurt. It's a female, 49 years old. She's complaining of an intermittent toothache. That brought her in to our office. The pain is episodic. The pain is in her bicuspids and her molars. So now you have to think to yourself, but when a patient presents in pain, and it's a dental pain, it's an odontogenic pain, it's the pain that you are sure is the one that you're going to be able to take care of. Is it normally in several teeth at once, or is it normally specific to a tooth? This pain was daily, it lasts hours, and her definition of it is continuous, steady, achy. Nothing makes it worse. Nothing makes it better. The pain is moderate in nature. What did the dentist find? What did I find when I was still practicing? Nothing. More of nothing. A root canal that when I palpated the area, tapped on the tooth, revealed nothing. There was no sinus-related issue. More of nothing. TMJ tenderness, opening okay. No deviation, no deflection. From an intraoral point of view, nothing. What did the x-ray show us? It's a pretty nicely done x-ray, pretty nicely done root canal. 2 canals, nothing really terribly obviously wrong. So what was done? What happened next? What do you think happened next? That's what the root canal looked like to start. They redid the root canal therapy. And you have to ask yourself, why? Now, I'm lucky enough to have been in practice a long time. I am sort of epigenetically centered to try to do something for a patient. And the patient wants you to do something. So you feel painted into a corner. The patient is pushing you. Do something, doc. I know it's that tooth. So after you do that and the pain doesn't go away, you take a panoramic and you search some more and you find more of nothing. What should I have done? What should we have done? What should we learn to do? We should learn to look at other areas of the face. In this particular case, there was marked tenderness of the left masseter. So the diagnosis then fell in line with myofascial pain and with a trigger point. Lauren?
So myofascial pain is basically pain that's characterized by taut bands and muscles, which are hyper-irritable areas, and they refer to a different site. So in this picture, you can see the X's are the trigger points and the dots are the sites where the pain is. So 1, for example, refers the trigger point that's in the superficial masseter refers to the maxillary posterior teeth. 2 refers to the mandibular posterior teeth. And I think the key here is that site and source are not always the same, so doing a comprehensive evaluation is key.
So what we're going to do now with orofacial pain is we're going to focus on the nuanced and the not so nuanced differences between dental causes of facial pain and facial pain causes of dental pain. We're going to share with you why we believe it's important to step back when evaluating a patient in pain, when at first blush, there is no dental cause. If you, who are the experts, feel there is no dental cause, then there is likely no dental cause. So now the question is, can we understand pain? My belief is that we can't understand pain unless we ourselves have felt pain. But what we can do is we can classify pain. So the Jefferson Headache Manual says that classification allows us to better diagnose them. And if we can better diagnose them, we can ultimately treat them. The ICOP that was run by Dr. Benolo L., Dr. May, and Dr. Svensson actually came up with a listing of reasons for dental pain that are non-odontogenic in source. And this listing has more than 39 causes. But the ISAP tries to define pain. They say it's unpleasant, but they remember that it's emotional. They say it's a personal experience, that the feeling, which is the nociception, is very, very different than the pain. The pain can be inferred, but you can learn. So 39 classifications. Now let's work on sourcing pain. Let's go to a real life case. You wake up, you open up your phone, and this is on your phone. You have a patient in pain. Your patient has already told you just a bit. How difficult is this? Your anticipation is that it falls within the 90%, and it's not difficult. We're going to forget about the social issues involved. That means, did this come at Friday at 4 o'clock or a Monday at 9 o'clock, or is your day full? Well, forget about that. This is what you see when you come into the office. You bring the patient in. You want to stop him from grimacing. You take an x-ray, and this one is absolutely a gift. You take a look. They're complaining of the upper left second bicuspid. You see a deep area of decay. You identify the deep area of decay. You know that you're going to be able to treat this. The level of difficulty of this particular case, this is acceptable. You're going to take care of it, and you feel pretty good about it. So now let's just spend a moment and review the common causes of a toothache, the 90%. So you have a cracked tooth, and the cracked tooth is nociceptive pain. You have a dental filling and it's deep or it's damaged. You have tooth decay. You have pulpal damage. You have sensitivity. Potentially the tissue is retracted. You can see the CEJ, you can scratch at it. You have gum disease. That's the 90%. Dr. Levi and I, we live in the 10%, which is the neuropathic pain, the cranial neuralgia, the myofascial pain, and the neurovascular pain. Those are the headache disorders. So we are lucky. You're the first funnel, we're the second funnel. So the question is, how do we work on understanding neuropathic pain? What is it we do? So let's start with the simple stuff. Patient comes in and says that it hurts when they have something hot. Test with something hot. Patient says that they have pain when it hurts with something cold. Test with something cold. Patient says that it hurts when they bite down. Either use a tooth sleuth, pick up a hammer, but you can figure out that the tooth is hurting. But what happens when a patient shows up like this? What happens when this is the X-ray? Non-carious enamel, intact lamina dura, no obvious osseous lesions, no occlusal trauma that you can see clinically. This patient is time-consuming. So now a patient comes in, another real-life case. My right gland under my neck is swollen. It hurts to eat anything hot or cold. What do? What do you expect to do? What do you expect to see? You expect to see some swelling, or at least palpate a swelling, or at least have the patient uncomfortable when you palpate the area. You expect to be able to have a tooth react to something hot or cold. You take a look at the X-rays. This is what you see. What do you think? How do you move forward? You take a closer look. You've done the intraoral testing. There is no reaction. There's nothing. Everything is nothing. Now you take a closer look. Still nothing. And a closer look yet. So what I did here is, through most of my practice, when I couldn't come up with an answer, I referred to the endodontist, my specialist on pain. The endodontist couldn't come up with a response either. But when he looked at the upper right first bicuspid and he saw the crack in the composite, he was ready to go ahead and do that. We both felt uncomfortable doing that, so we took another look. And this is what we saw. On the right canthus of the patient's eye, there was a vesicle. I don't know what drew us to it, but this was a patient with herpes zoster, and the pain was neuropathic. And because the zoster was so close to the eye, I believe that the patient was incredibly fortunate that we were able to pick this up early and prevent any movement to the eye. Here's another patient with a similar complaint. You look at these X-rays and you could really find the reason. Look closely at this. You can absolutely find the reason, but every tooth tested normal. Every tooth tested vital. But when we pushed the envelope, once again with the endodontist, it was, well, maybe 14 or 15 is a little bit non-vital, and maybe we'll try. But then we saw this on the border of the nose. And what we had was another case of zoster, another neuropathic cause. And the neuropathic causality was mimicking tooth pain. So now you have to say to yourself, what do you have to think to yourself? You have to say, is this pain chronic? Is this pain infectious? Is this pain inflammatory? We all know the case of a patient coming in for a cleaning. The hygienist is aggressive, but not terribly aggressive under the operculum. The tissue the bacteria gets trapped down deep and the patient comes back in pain. Is it musculoskeletal? Is it orthopedic? Is it the one thing that almost everyone always turns to and says, it's TMJ? But the question is it really? So now let's listen to what the patient says. Does the patient say that it's achy, heavy, dull, cramping, throbbing? Does the patient say that? Then it's likely musculoskeletal. Does the patient say it's shooting, sharp, electric, hot, burning, radiating? Then it's likely neuropathic. So now we deal with the question of what is neuropathic pain? Dr. Levy?
So before kind of going over what neuropathic pain is, we have to go over what's nociceptive pain. Nociceptive pain is protective pain, or what some people will call the healthy pain. It lets you know that whatever you're touching is sharp, and so you should stop touching it, or whatever you're feeling is too hot, you should stop touching that. It's caused by a noxious stimuli. Neuropathic pain, in contrast, well, before I get to that, nociceptive pain is mainly mediated by two fibers, A delta and C. A delta fibers respond mostly to mechanical and thermal stimulation, and that allodynia and they're responsible for allodynia that you might see in a cracked tooth syndrome or reversible pulpitis. C fibers, which are unmyelinated, are more responsible for the dull, episodic, spontaneous, intense throbbing pain that we see associated with irreversible pulpitis, as well as that sensitivity to heat. But neuropathic pain is not protective in nature. It's unhealthy pain, and it's caused by a dysfunction of the nervous system, and it doesn't require noxious stimuli. So you could be just having a gust of wind touch your face, which that shouldn't cause pain, and it does. It brings you to your knees. Or you can just put your shirt on, and it shouldn't hurt to put your shirt on, but it's very uncomfortable for the shirt to even touch your skin.
So for those of you who remember the movie The Sunshine Boys with Walter Matthau and George Burns, there was a vaudeville routine where they're up on stage and one fellow pokes the other in the arm and says, "Doctor, doctor, hurts when I go like that." And the doctor says, "Don't go like that." That's nociceptive pain. That's the body acting as the doctor saying to you, don't do what you're doing. That's going to cause a problem. But neuropathic pain is your brain takes over. And it's not a protective pain. It's a pain where your brain is telling you that it hurts, but it's not telling you why it hurts. So at this point now we're experts. Let's do this one together. My toothache will not go away. Once again, toothache, brought the patient into the office. 29 years old and married, 7-year history of left-sided pain. 7-year history. I think we'll call that chronic. Episodic, 2 or 3 times a month. Is toothache pain really normally only 2-3 times a month? Does toothache pain last 7 years without localizing to a tooth? It began with the upper left molar and radiated to the temporal and left orbital region. It was described as, let's listen to the words, blinding, throbbing, sickening. And it hurt pretty bad. But yet, nothing set it off. But it was increasing in intensity. And it lasted about 8 hours. The doctor, who was often a significant referral to the dental office, sent the patient over. What was found? Nothing. Nothing. Tooth 14, which is the upper left area, was not sensitive to percussion or palpation. Nothing. Nothing again. Nothing again. Nothing again. But there was slight attrition. So a lot of people, once again, after the patient pushes and pushes and pushes and says, "Help me out of this pain," they reach for a straw. And the straw here is an appliance. What was done for this patient? This practitioner did what I did. He called the dentist. He called the endodontist. What did the endodontist do? a root canal. But you have to ask yourself why. Why was the root canal therapy done? What wasn't done? What could have been done? What are we all capable of doing? Asking questions. The patient had light sensitivity or photophobia. The patient had sound sensitivity or phonophobia. The patient had nausea and vomiting. And at times, the vomiting made the patient feel better. What's this starting to sound like? The patient's husband reported frequent episodes of nocturnal tooth grinding. Well, the lady was in pain for 7 years. Of course, she's going to grind her teeth. She was treated with anti-inflammatories. What was this? This was a migraine. Dr. Levy?
So migraine is a neurological disorder. It lasts 4 to 72 hours. It's characterized by nausea and or vomiting, photophobia and phonophobia. And I think the key here is to ask a detailed history. Had perhaps we asked the patient if they had nausea or vomiting, they would have told us. But sometimes patients don't think to give this information. So we have to be very good history takers in order to become better diagnosticians.
So the patient was given Imitrex. There were no objective dental findings, and that was it. So now we begin with what should be your examination roadmap. What should it be? Of course, you should know the chief complaint. Then you should know the location of the pain in relation to the chief complaint. Then you should try to understand the type of pain that is being described by the patient. And then you have to go over headache history, because neurovascular sources for facial pain are incredibly common and often missed. And really, this is the evaluation roadmap you should do. Dr. Levy?
So I think the key here is 90 to 95% of your diagnosis can be gained from a detailed history. And it's key to try to go through and make sure not to miss anything. At the beginning, it could seem a little overwhelming, but as long as it's systematic, it becomes second nature. So asking patients, what brings you in today? Tell me about, what makes the pain better? What makes it worse? When did it start? Where does it hurt? The quality, what does it feel like? As well as going over everything that it says here. So the family history, past medical history, social history. Do they have any past treatments? And I mean, I could go on, but the idea is the more questions that you ask, as long as you have a clear, systematic approach to asking those questions, the better you'll be at being able to find all of these conditions that are not as common, but still can occur in your office.
So let's go to a case that's reported. This is not our case. This is a case that was reported. I cover the diagnosis up for an obvious reason. I don't want you to see it till the end. But you know already that this was diagnosed as a temporomandibular disorder. So let's start. This is a 67-year-old woman who already went through the double funnel and came to the Orofacial pain clinic complaining of a left temporal headache. She had limitation of mouth opening. So now you're thinking. She has pain on chewing. Oh, you're thinking a little bit more. You already think you have a diagnosis. She reacts positively in terms of feeling better to Tylenol and Dipyrone. Dipyrone is not available in this country, but it's a simple over-the-counter analgesic, antipyretic, anti-inflammatory. Okay, so what happens next? Next, she goes to the ER. And in the ER, she has an erythrocyte sedimentation rate of 70. Oh, that's something. And it's different. And it's normally in line with the differential diagnosis of giant cell arteritis or temporal arteritis. But the dentist or the ER physician also notices, based on her jaw discomforts, that she has osteoarthritis of the temporomandibular joint. And as a result, they make a decision that the patient has osteoarthritis of the temporomandibular joint. And they send her home. She goes to her dentist, and her dentist takes out her lower left first molar. And I'm going to ask the question that I asked before. Why? What was the motivating factor? Once again, this was a patient in pain who kept saying, do something, do something, do something. And somewhere in that discussion, the lower left molar was pointed to. And they grasped at straws, but there was no relief of pain. And as a result, the patient returned to the ER. And when the patient returned to the ER, she now said that the pain was sudden. She pointed to her left ear and left TMJ and left temporal area. She now described the pain as pressing and pulsating. It now became continuous and was gradually worsening, and the pain was pretty bad. But now you start to hear other things. The pain lasted seconds to an hour and a half. The pain was associated with nausea, vomiting, and photophobia. So now you're thinking, could it be migraines? I didn't think of that before. It could awaken the patient from sleep. Migraines can do that. Attempting to chew or open the mouth or lying down aggravated the pain. Migraines don't ordinarily do that. And the pain was not aggravated by physical activity, and there were no autonomic signs. But migraines are ordinarily aggravated by physical activity. And as a result, they took a closer look at the mouth, and they came up with nothing. But what did they then decide? They then decided that this was likely not osteoarthritis of the TMJ, but giant cell arteritis, where they quickly referred the patient to the ER to take care of it. Dr. Levy?
So giant cell arteritis, also known as temporal arteritis, is often characterized by a tender temporal artery. And it's not something we want to miss because it can cause vision loss, right? So the key here is, again, taking a detailed history, thinking outside the box, and making sure that while this is not that common, this is definitely not something you want to miss.
Once again, a reported case. My pain is so bad, I want to kill myself. 36 years old and married. Referred by the ENT, who obviously didn't figure out the answer. Right-sided facial pain, temporal and infraorbital. 6 weeks duration. No aggravating or relieving factors. Hospitalized by the ENT. Consultations with the oromaxillofacial surgeon, the dental GP, and dermatology. I haven't figured out the dermatology part yet, and I didn't see it in the article. Pain duration, 90 to 180 minutes, and visual disturbances. And so we're now reporting autonomic signs. Most during the day, but wakens from sleep, and a history of temporal mandibular dysfunction. What were the findings? The MRI and CT scan were normal, but there was a restriction of jaw opening, so we're finding something. There was only a comfortable open of 15. Well, we know rotation takes us to 20 to 25, so the patient wasn't even finishing rotation. Forget about translation. There was tenderness to the TMJs, masticatory, and cervical muscles. Oh, something's going on. What was done? A right TMJ steroid injection. You know, it makes a little bit of sense, but unfortunately, it didn't cause a complete cessation of pain. That's because it can be more than one thing. What wasn't done? A thorough exam. What was found? This was a gift. During the course of the exam, pain developed during the exam. What could be better to help in diagnosis? It got better, not for the patient. The patient curled into a fetal position and rocked. His right eyelid drooped. His visual issues became more profound. He couldn't speak, and not because he had a rubber dam in. And this is what he looked like. It's not a tooth. It's not a TMJ. It's a cluster headache. And it's a cluster headache with a secondary diagnosis. Dr. Levy?
So cluster headache is a type of trigeminal autonomic cephalgia, which is a type of primary headache disorder. And It's unilateral. It's accompanied by autonomic features, as Dr. Mansdorf just discussed with his patient. So the droopy eyelid, runny nose. And what's key about cluster headache is it's also accompanied by restlessness. So in this situation, the patient was rocking, they were pacing, patients often will go like this.
And the number of times that a cluster headache will first present as a toothache is significant. So here are 4 terrific cases. Dr. Nixdorf has spoken to this group. The man is just terrific. And you have to understand that pain is often referred from the somatic I'm reading this, from the somatic counterpart of the intracranial structure, and it goes to the areas that we take care of: the face, the jaws, and the teeth. So let's go through these 4 cases. We're going to go through them quickly because you're experts now. Okay? The patient has dull, aching, throbbing pain. It was intermittent and forced the patient to go to bed. What are we thinking about already? But this patient saw an endodontist, a TMD practitioner, an oral surgeon, a chiropractor, a massage therapist, a neurologist, probably went to have her nails done and her hair done, 4 root canals, 3 extractions, occlusal splint, neck adjustments, massage, and then someone gave her carbamazepine, which is normally used for TN. But she also had nausea, vomiting, light and sound sensitivity, and it was made worse with activity. So we already know what this is. This was a migraine. We know that already, just from the time we spent this evening. Now we have a 48-year-old white male with a chief complaint of toothache. That's why they're in your office. They have eye tearing, facial swelling, and increased temperature. Now we know already. Autonomic signs. Sleeping and increased physical activity had no impact on his pain. We know now that it's not likely a migraine. What was this? This was another cluster headache. We have a 64-year-old female with left maxillary pain. That's why she's in your office. 5 times a day, lasting 5 to 10 minutes. Wakes her from sleep. Nasal congestion. Autonomic signs. Splint therapy and bite adjustments. It's what we do when we don't know what else to do. Paroxysmal hemicrania. We'll spend more time on that in a moment. The last one of these 4 cases. There's a dull soreness in the right maxillary molars. That's why the patient's in your office. Pain exacerbation from physical activity. Now you're thinking, ooh, I know this one already. Tearing in the right eye. Ooh. Extraction by the dentist. Cervical adjustment by the chiropractor. Multiple chronic pain medications. What is this? We have to ask questions. Hemicrania continua. This pain was always on one side and never shifted. So headache disorders can present anywhere in the trigeminal area, and we have to be prepared for that. And it is incredibly important that dentists be able to identify headache sources that cause dental pain. So this is the Association of Migraine Disorders, the short video that Dr. Levy is going to narrate. I'm going to stop it every once in a while.
So paroxysmal hemicrania and hemicrania continua are 2 types of trigeminal autonomic cephalgias. The other 2 are cluster headache and SUNCT, or SUNA. SUNA and SUNCT are 2 different conditions, but they're very similar. And we can kind of differentiate them. Well, what's similar about all of them is they're all unilateral headaches, and they're all accompanied by autonomic symptoms, meaning eye tearing, pupillary constriction. You can see it says some of those. But when we compare the 2, paroxysmal hemicrania and hemicrania continua, paroxysmal hemicrania is paroxysmal in nature, so it only occurs, at short bursts, right? 2 to 30 minutes, versus hemicrania continua lasts continuously, right? There's no periods of relief.
So now let's go into another case. Once again, I covered the diagnosis, a non-odontogenic toothache. 70-year-old, right-sided pain, triggered by movement associated with eating. intermittent pain lasting seconds, you should already start thinking of something. Consulted 5 dentists, removed the lower right implants, and extracted molars following root canal therapy. So let's do this backwards. Patient had root canal therapy, then posts, then crowns, then extractions, then implants, then crowns, then removal. Everything seemed fine, but the two interesting things was that a lower right block stopped the pain during the anesthesia. You'll hear more about that in a minute. And the pain cleared up for 6 months. And this is what the patient looked like after treatment by the multiple dentists. This is what the patient looked like. And this was the case of trigeminal neuralgia. Dr. Levy?
So trigeminal neuralgia is characterized by sharp shooting bursts of excruciating pain followed by periods of remission. There is a type of trigeminal neuralgia that's not as commonly seen, but can be seen sometimes where there is a background pain. There was a paper written in the Surgical Neurology International, as you see here, and they cited several studies where patients had teeth extracted when in reality the patients were diagnosed with trigeminal neuralgia, and the extractions were unfortunately unnecessary. And I think that we highlighted here the conclusion of the paper, which was pretty profound and well written, and it just says how powerful and important it is to make sure that you're thinking outside the box and that you're collaborating with other specialists, right? So if it doesn't fit what you think is as a toothache, maybe it's not a toothache, and maybe you should consult with an orofacial pain specialist or a neurologist or a neurosurgeon. As well as you can say the same thing. If, neurology thinks, hey, this doesn't sound like TN, perhaps it is dental, then they should be sending it to dental. And it's important that we work together because pain really is a multidisciplinary field. So when we see these non-odontogenic toothaches, it can be overwhelming, but something that is easier to help us diagnose is diagnostic anesthesia, right? So we can start by going over some basic things. We know when we have a traditional odontogenic toothache, meaning what do? We can numb the tooth up with anesthesia and the tooth is out of pain, and we can do our, crown or our restoration or endo, right? Other things that respond positively to diagnostic anesthesia is trigeminal neuralgia, which is helpful because you can get the patient out of pain right then and there, and they can continue telling you their story, but also it's helpful because it helps us diagnose the patient as saying, okay, well, actually, this sounds like it's TM. In terms of conditions that don't respond to anesthesia, myofascial pain is one of them, right? So in order to get a patient out of pain when they have myofascial pain, we need to be anesthetizing the trigger point rather than the tooth. Right? Same thing is true for migraine. If a patient comes in with a mid-face migraine and they're complaining of tooth pain and you anesthetize the tooth, it will not respond. Same is true for sinusitis. You try to anesthetize the tooth, it will not respond. Finally, the last one that we go over here, just touch on, is post-traumatic trigeminal neuropathy. You can put neuropathic pain in this category as well, which doesn't always respond. It's equivocal. Sometimes you'll get a response, sometimes you won't. And sometimes the patient will say, it helped a little bit.
So remember that PTTN is a neuropathic pain, and it's actually not that terribly uncommon, and it needs to be considered as part of what we're doing. So to review, there are many, many, many faces to orofacial pain. We see, depending on the literature, between 50 and 80% of the people that come into our offices are coming in for pain. Of that 50 to 80% of people who are coming for pain, we're going to successfully take care of 90% of them, which is why dentists should be incredibly proud of the job they do. But for the other 10%, you have to reach out to other practitioners in other fields. You have to reach deep into what you already know is true, and you have to be able to send your patient out to the proper place, the proper treatment. I would like to thank you so much for allowing us to spend this time with you this evening, and we truly hope that this very, very superficial overview of facial pain will be helpful to you as you go forward in practice.
Yes, thanks for having us.